Hi everyone. In our lecture today we will be talking about the autonomic nervous system. You've had your lecture on the anatomy of the autonomic nervous system, and so this lecture will be focused on the function, both the normal function and also what goes wrong in a variety of conditions where we have a distortion of the autonomic nervous system. So as you know, autonomic nervous system essentially describes a part of the nervous system that is self-governing, and it functions independent of conscious control. It's happening all the time with regards to our breathing, our heart rate, our GI tract, independent of conscious control. So with regards to the sympathetic and parasympathetic systems, I won't be talking about the enteric system today. We have ganglia that are located in the central nervous system. Okay, and so we'll show you that for sympathetic, these are located mainly in the thoracic spinal cord, and for the parasympathetic, there are certain cranial nerves that have a parasympathetic contribution, and then all the way down in the sacral cord. Okay, then there's a preganglionic fiber, a ganglion, and then we have a postganglionic fiber that goes out to effector tissue. Now, the head ganglion of the autonomic nervous system is the hypothalamus. Okay, and this is not neuroanatomy, so we're not going to have you identify anything in the brain, but the hypothalamus is this area up here in the brain. Okay, it is the head ganglion for the autonomic system, sympathetic and parasympathetic. Now, there are areas of the brain that regulate the hypothalamus. Okay, and so we'll be talking about two structures here, the amygdala and the hippocampus. These are in the temporal lobe of the brain, and I'll give an example of how that works. So we think of, I remember when I learned to drive, my dad said, you either have your foot on the gas or the brake, you don't use both. And it's kind of like that with the autonomic system here. One is active, and the other is inactive, and vice versa. And so for the parasympathetic system, this is involved in rest and digest, more sedentary activities. Sympathetic kicks in our fight or flight response. So it's helpful to contrast this here with somatic motor neurons. This is our lecture last time on the neuromuscular junction, which is way out here with the release of acetylcholine on nicotinic receptors. And so we're going to talk about these conditions of the neuromuscular junction and describe how many of these do have autonomic dysfunction as part of them. Okay, so for movement, whether we're talking about anterior horn cells in the spinal cord that send nerve projections to move your arms and legs, or cranial nerves like the facial nerve or the hypoglossal nerve that moves your face or your tongue. All movement for cranial nerve musculature and for your arms and legs involves release of acetylcholine and the stimulation of nicotinic receptors on muscle. And so last time we talked about the snare proteins that are necessary for the release of acetylcholine, and also how nothing happens unless we activate these voltage-gated calcium channels and have an influx of calcium. Now, with regards to the parasympathetic system, the fibers here are what we call craniosacral. So we can see there are some associated with cranial nerves here, and others that are all the way down here in the sacral spinal cord. Okay, so remember all of this. So here's our preganglionic neurons, here's our preganglionic fiber. It's going to go through a ganglion. Okay, and this involves release of acetylcholine on nicotinic receptors, but notice I'm calling these N2 receptors. If we back up a slide on the neuromuscular junction, we call these N1 receptors, right? So here are the nicotinic receptors at the neuromuscular junction. This is extremely important. These, yes, they are nicotinic receptors, but they're morphologically different than the nicotinic receptors on muscle. And you'll see why that's important here in just a little bit. Okay, so we have acetylcholine, nicotinic 2 receptors here, and then we have acetylcholine again released on effector tissue, pupil, salivary glands, heart, lungs, GI tract, bowel and bladder. Okay, and so all of this on the effector tissue is acetylcholine that stimulates muscarinic receptors. Now, I'll emphasize this point again, but when we talked about release of acetylcholine at the neuromuscular junction and how snare proteins are needed, voltage-gated calcium channels have to be activated, the same thing is necessary for release of acetylcholine out here on effector tissue. Okay, we still need voltage-gated calcium channels and influx of calcium. We still need snare proteins involved in release of acetylcholine here, just as we saw at the neuromuscular junction. Okay, that point is key to understanding which of these neuromuscular junction disorders will have some parasympathetic dysfunction. Okay, our sympathetic preganglionic fibers are located, you can see in the thoracic cord and down into the lumbar cord as well, mainly from T1 to L3. Okay, and so these are talking to the same areas as the parasympathetic was. I mean, everything is the same here in these two diagrams. It's just it's doing exactly the opposite. Okay, so sympathetic, again, there's a ganglion. So we have these prevertebral and paravertebral ganglion that anatomy talked about. Okay, and it's just like with the parasympathetic system. We said this is acetylcholine, nicotinic 2 receptors. These are also acetylcholine, nicotinic 2 receptors. But now out here on the effector tissue, it's not acetylcholine, with one exception. It is norepinephrine, okay, that are stimulating alpha and beta adrenergic receptors. Okay, the only exception not shown here is that acetylcholine is only used on effector tissue for the sympathetics on sweat glands. So there we do have acetylcholine with muscarinic receptors. Now, one additional point here that's important about the sympathetic system is that the adrenal medulla, it's really a displaced ganglia of the sympathetic system. Okay, and so it releases predominantly epinephrine and also some norepinephrine. Okay, the neurotransmitter on effector tissue for all of these sympathetics here coming from the thoracic cord is mainly norepinephrine. Okay, and here's just a section of the spinal cord. Again, you don't need to know this for now, but this is the thoracic cord, and we can see these little preganglionic neurons located here and over here. Okay, not important, just to kind of wanted to give you a frame of reference. Okay, so I said the adrenal medulla, it's like a displaced ganglia of the sympathetic system. And so these neurons here in the thoracic and lumbar cord can activate the adrenal medulla. And so remember here that this is predominantly epinephrine that's released. Okay, and this has a very powerful effect, a systemic effect throughout the body. That's actually worthwhile saying something about. When you stimulate the adrenal medulla, epinephrine just blasts the entire body, has a widespread effect. And just contrast that with here, when we're talking about the pupil and the salivary glands and the lungs. This is a point-to-point relationship, okay, where we have norepinephrine either stimulating or inhibiting these areas. Okay, but when the adrenal medulla is activated to release epinephrine, it just goes throughout the entire body, has a widespread effect. That's what we mean by systemic. Okay, and in addition, the adrenal medulla, when it's activated by the hypothalamus and the pituitary gland, releases glucocorticoids such as cortisol, which I won't tell you about now, but that will be important as you'll learn later. So again, the overall function of the sympathetic system is to elevate your heart rate and blood pressure. If you're in fight or flight mode, you want fuel stores mobilized from muscle and fat so you can spring into action. Your pupils dilate because I guess, you want to see everything during an emergency situation. Okay, we have piloerection, which means your hairs stand on end. There's some sweating. Again, the acetylcholine muscarinic receptors on sweat glands are supplied by sympathetics. Okay, we have constriction of blood vessels in the skin and GI tract because in fight or flight, we're not interested in digesting food or peristalsis. We want blood diverted to muscles in areas where you need it. Okay, there's increased bladder sphincter tone because we're not rest or digest. We're not trying to urinate at that time. The bronchioles dilate because you want to be able to oxygenate. Okay, and you slow GI tract peristalsis. So actually, exercise mimics here the activation of the sympathetic system. It's not fight or flight emergency mode, but when you exercise, your heart rate needs to go up, your blood pressure needs to go up, you need to mobilize fuel stores, you're going to sweat, you're going to reroute blood to muscles, for example. Okay, we're not going to, go to the bathroom during that time. We want bronchial dilation, so we increase oxygenation, and this is not the time to be involved in peristalsis. Okay, so exercise overlaps here a lot with sympathetic function. Now let's describe here a big picture of how this works, starting from the brain. So there's an area of the brain called the amygdala, which you can see located here, kind of at the tip of the temporal lobe. And think of this as like the fire alarm in a school. It gets pulled immediately when there's an emergency. Someone smells smoke or whatever. So the amygdala gets activated, and if you've ever been startled by even someone that sneezed in class or something like that, and you felt your blood pressure and heart rate go up just very briefly, that's still the amygdala, okay, that is activated. So how does the amygdala stimulate all of that to happen? Well, it activates the hypothalamus, which is right adjacent to the pituitary here. So remember, this is the head ganglion of the autonomic nervous system. The hypothalamus then sends fibers down, and I'll show you these actually in the neuroscience course, down to the thoracic and lumbar cord to activate all of these sympathetic preganglionic neurons. So the result is, in that moment, let's say you're trying to get to sleep and you hear a loud noise and you wonder if someone's trying to break into your home. Okay, this is all going to be activated here. Amygdala, hypothalamus, pituitary, and then your sympathetic preganglionic neurons here. Your pupils are going to dilate. Okay, we're not interested in salivating during that time, so that's going to be inhibited. Your bronchioles will relax, so you can get oxygen. Your heart rate is going to accelerate, and your blood pressure is going to go up. Okay, we're going to inhibit peristalsis of the GI tract, and this is, again, relax the bladder and contract the rectum because you don't want to go to the bathroom during that time. Okay, so all of that is happening instantaneously. Now, the adrenal gland is also activated here by the thoracic and lumbar cord. So epinephrine is released. This contributes further to elevated blood pressure and heart rate and so on. Okay, and by something that's really complicated, I can't show you now, but the hypothalamus and the pituitary also stimulates the adrenal gland to release glucocorticoids, or cortisol. It's the most common form there, which also has a systemic effect that contributes to the fight or flight. Okay, now, let's say you hear that loud noise in the middle of the night and you get up and you investigate. And so there are areas of your brain that kind of rationally will evaluate this. A lot of the frontal lobe, we call this area the prefrontal cortex, and the hippocampus. The hippocampus actually has lots of glucocorticoid receptors. So when the adrenal gland releases these glucocorticoids in fight or flight, this is how your brain becomes alert in a more conscious, rational way that something is going on. Okay, so your prefrontal cortex, your hippocampus then are in investigative mode. And if it turns out that someone is really breaking into your house, then they're going to stimulate the amygdala to further drive more fight or flight response. Okay, if it turns out that it was just a car that backfired outside your home, nothing serious, then the hippocampus and the prefrontal cortex up here can shut the amygdala down, and it takes a little while, but eventually your heart rate and blood pressure and all of that drop back down. Okay, so that's an oversimplistic view of activation of the sympathetic system during fight or flight. Let's talk about what can go wrong. So in conditions like anxiety disorders, individuals that have panic attacks, or post-traumatic stress disorder, I work at the VA hospital, so I see a lot of veterans that relive things that happened decades ago. And it does the same thing I just described. It activates that whole, from the amygdala to the hypothalamus to the whole sympathetic system. So these individuals have persistent, inappropriate firing of this entire cascade. Okay, and sadly, this can be activated in the absence of any stimulation. They don't need to hear a loud noise or something. They'll just spontaneously have this whole system activated. And this is quite harmful to the brain. We know now that persistent overactivation of the sympathetic system leads to these inflammatory cytokines, which actually can damage the hippocampal glucocorticoid receptors. And remember, that's part of your feedback loop. That's how your brain recognizes something's going on, and it's also how your brain is able to shut it down. So if you destroy these areas, your brain becomes less able to inhibit this fight or flight response. So that's why it's actually very important that when individuals have anxiety, panic disorders, or PTSD, that we treat it, because there is structurally bad things that are going on, with recurrent untreated panic attacks, PTSD. Now let's talk about a focal dysfunction of the sympathetic system. And so remember that here we have the pupil, okay, which is dilated by the sympathetic system, okay, but it is remarkably complex how your sympathetic system dilates your pupil. It's a 3-order neuron chain. So remember, the hypothalamus is the head ganglion of the autonomic nervous system. So actually, dilation of your pupil starts way up here in the hypothalamus. Okay, this travels all the way down to the upper thoracic cord, maybe even a little bit of C8. Okay, so these are your preganglionic sympathetic neurons here. And we have a preganglionic fiber that loops over the lung, around the subclavian artery, goes up to a ganglion here called the superior cervical ganglion. Okay, and then from here, we have, traveling with the external carotid artery, information to blood vessels and sweat glands. Remember, sweat glands, these are acetylcholine, muscarinic receptors. And then another fiber goes up along the internal carotid artery via a very complex route, which you do not need to know. Please don't try to memorize how these fibers get to the pupil, but they do go up along with the internal carotid artery and eventually end up going to the pupil to dilate the pupil. And in addition, they supply a muscle here called Mueller's muscle, which is a minor eyelid elevator. Okay, it has a little contribution to eyelid elevation. So all of this is to dilate your pupil and to a little bit help you elevate your eyelid, and also supplies sweat glands for sweating in the face area. So a lesion anywhere along this pathway, from the hypothalamus down to the upper thoracic cord, to the superior cervical ganglion, or these fibers as they travel along with the carotid artery, can impair the ability for the pupil to dilate. Okay, so patients who have a lesion anywhere along this course look like this. Okay, well, you don't supply Mueller's muscle, so you get a little bit of a droopy eyelid. That's called ptosis. You don't pronounce the P, it's just ptosis. And also, since you lose the ability to dilate the pupil, now the parasympathetics are relatively overactive. And so the pupil constricts a little bit. That's called miosis. Okay, so we can see this pupil is a little bit smaller than this pupil. Now, the most helpful thing to do when we see someone with an asymmetrical pupil like this is just dim the room lights a little bit, or turn them off. I mean, obviously you need to still be able to see the pupils, but dim the room lights, okay? Because what's going to happen? The normal pupil here, the sympathetics are going to kick in when you dim the room lights, so you can see better, so the pupil dilates. Here we have a sympathetic dysfunction. You can't activate this pupil to dilate. And so the reason this is so helpful is almost 1 in 5 individuals have some mild pupillary asymmetry. Very, very common. And but when you dim the room lights in that condition, the pupils stay about the same degree of difference between them. Okay, when you have a sympathetic lesion, the pupillary asymmetry becomes dramatic when you dim the room lights. Okay, so this is just a really helpful thing to do. Now, this is a very high-yield board question, and I don't like to throw that out easily, but it is truly a favorite board question, and that is they will give you a smoker who has a Horner syndrome. Okay, and what they're looking for there is a cancer at the apex of the lung. Okay, so lung cancer here can give you a Horner syndrome, and in the neuroscience course we'll talk about many other causes of Horner syndrome, but that's the high-yield board question. Okay, so the triad for Horner syndrome is meiosis, smaller pupil, ptosis, and you can also get some decreased sweating around the eye and the face. That's called anhidrosis. Practically, that's really hard to appreciate. Now, I want to say just a little bit about afferents, incoming information to the sympathetics, just because there's a little bit of a payoff for understanding some clinical conditions. So from all of the internal organs, you have information. It needs to get up to the brain, and it goes through sympathetic fibers. And I'm not going to ask you any of this anatomy. I'll tell you the big point I want you to get away from this. Okay, and it's coming into the spinal cord at specific levels. Okay, so we can see, for example, that here with the stomach and the duodenum, if you have an ulcer, well, this may get into the spinal cord at around the T6 level. The reason this is important is that when things are going wrong with internal organs or structures, the localization of the pain is not exactly where that organ is located at. The localization of the pain has to do with which level of the spinal cord those pain fibers enter. Okay, so, for example, here's a kind of a classic dermatomal map. Okay, so we can see C3, C4, C5, C6, and so on. Notice the T1 fibers go down the medial aspect of the arm. Okay, and so with all of the internal organs and the diaphragm, pain is referred to the dermatomal level, the level where it enters the spinal cord. So the classic example is myocardial ischemia, a heart attack. Okay, the patients may not feel that the pain is right over the heart because those fibers enter the spinal cord at the T1 through T5 dermatome level. Okay, so that's why myocardial ischemia, the patient will often say their shoulder hurts and they have pain going down the arm because a lot of these fibers for the heart enter the spinal cord at T1. So that one's important. The liver and the gallbladder, because of where these enter, the pain is often felt at the tip of the right scapula. Okay, and diaphragm pain can be referred to C3, 4, and 5, which is kind of the upper shoulder area. So again, this is known as referred pain. And so if you're an emergency room doctor and someone is coming in, with shoulder and arm pain, well, you better have something serious in your differential here and not miss myocardial ischemia. Now let's talk about the parasympathetic system. Again, the fibers here are craniosacral, okay, and on effector tissue, it's acetylcholine stimulating muscarinic receptors. And atropine we'll come back to as a medication, actually, which potently blocks muscarinic receptors. Okay, so now we'll be going into just the opposite thing here with the parasympathetics. It doesn't dilate your pupil, it constricts your pupil. It stimulates everything that has to do with digestion, including the salivary glands. It doesn't accelerate your heart rate, it slows your heart rate down. It constricts the bronchi. Okay, it stimulates peristalsis, and it's important for urination and defecation by contracting the bladder and relaxing the rectum. Now, there's a lot of anatomy here, and in terms of the cranial nerves, so remember it's craniosacral. Okay, I would only like you to know, and will only ask you in terms of the anatomy of what's involved with regards to the pupil. So 3, 7, 9, and 10 are the cranial nerves that have an autonomic function. So I would like you to know that the parasympathetic system is important for tearing via the lacrimal glands, but I'm not going to ask you the ganglia or the nucleus. And that they are important for salivation through stimulation of the salivary glands, and including the otic ganglion for the parotid gland. But this is not anatomy class. I'm only wanting you to know this because it has a real payoff for understanding an important clinical condition. Okay, and we've got the vagus nerve, the wandering nerve, which just does so much. This is how the lungs constrict and how the heart rate slows down and how we stimulate peristalsis and release of bile. And this is important for urination and defecation with regards to the sacral preganglionic parasympathetic fibers. So I want you to know the function, but anatomically, we're just going to focus here on the parasympathetic contribution to the third nerve. Okay, so here it is. In the neuroscience course, we'll talk about how light comes in to activate the parasympathetic system. All I want you to know for now is that the preganglionic neurons here for the pupil are called the Edinger-Westphal nucleus. Okay, this has nothing to do, so these fibers do contribute to your third nerve. Here's the third nerve here, but it has nothing to do with moving your eye or elevating your eyelid. That's a separate function of the third nerve. So when we say the Edinger-Westphal nucleus, we are only talking about the parasympathetic fibers that have to do with constriction of your pupil. So the preganglionic fibers here go through the ciliary ganglion, and then from the ciliary ganglion out to the pupil to constrict your pupil. Okay, that's the normal function. So if you have a disruption anywhere here from the Edinger-Westphal nucleus out to the pupil, okay, you're going to lose the parasympathetic tone to constrict your pupil, and now the sympathetics would be relatively overactive and the pupil would be dilated. And that's exactly what happens in this condition known as 80s tonic pupil. And it isn't really known usually what causes this. It's often just young, healthy women that have a spontaneous degeneration of the ciliary ganglion. So the parasympathetic fibers have no way of getting to the pupil. So most of the patients that I have seen with this, they wake up in the morning, maybe putting makeup on, looking in the mirror, and they notice a big dilated pupil. Okay? And often they come to the emergency room because, that doesn't sound good to have a dilated pupil. But if everything else is normal, then we can localize this here to a problem with the ciliary ganglion. And unfortunately, this is kind of an annoying condition because if your pupil is dilated all the time, you're going to have more light sensitivity. So that's often kind of the complaint these patients have. Okay, in the neuroscience course, I will tell you about a really cool way to diagnose this condition, but that's not really the function of this lecture. All right, so we have, again, just contrasting syndromes here. Horner syndrome is a sympathetic problem. You get a small pupil. Okay, 80s tonic pupil is a parasympathetic condition, and now we get a big dilated pupil. Now let's revisit our neuromuscular junction conditions from last week's lecture and consider which ones will or will not have autonomic dysfunction. So first of all, Lambert-Eaton syndrome. Okay, so we know that from last week that in this condition we have antibodies against the voltage-gated calcium channel. we don't release acetylcholine at the neuromuscular junction. You don't therefore stimulate the nicotinic receptors, and so patients are weak. Okay? Well, it turns out that voltage-gated calcium channels are also involved in release of acetylcholine by the parasympathetic system on effector tissue, the acetylcholine that goes to muscarinic receptors. Okay, exact same thing, these junctions, or what's happening here with the parasympathetic system is exactly the same, except now the acetylcholine is going out onto muscarinic receptors on the heart or the salivary glands or whatever. So patients with Lambert-Eaton syndrome do have autonomic dysfunction. And in theory, it could affect anything over here, but almost always the two that are mainly involved in Lambert-Eaton syndrome are the salivary glands. So these patients complain of a dry mouth. That's a big complaint. And they also lose the stimulation here of the GI tract. And so constipation is another big complaint of Lambert-Eaton syndrome. Those are the two most common. Okay, so again, think of a smoker who's coming in with weakness, but in addition, they're going to have dry mouth and constipation. Now, what about myasthenia gravis? Myasthenia gravis, recall, has antibodies against the N1 nicotinic receptors at the neuromuscular junction. And so this is really important, and I think probably a common question you might get on boards. Myasthenia gravis, you are therefore only allowed to have weakness, nothing else. Okay, so that can be weakness of ocular muscles, remember the droopy eyelids, double vision, can be weakness of bulbar muscles, producing dysarthria and dysphagia, and it can produce weakness of neuromuscular junctions in the arms and legs, producing weakness. Okay, but these nicotinic receptors on muscle have absolutely nothing to do with the autonomic nervous system. So there is no autonomic dysfunction in myasthenia gravis. Pupils normal, salivary glands normal, GI tract is normal. Okay, and remember that those nicotinic receptors out here and here, yes, they are acetylcholine, but it's a N2 nicotinic receptor, not an N1. N1 are the ones that are out here at the neuromuscular junction. So the autonomic nervous system is normal in myasthenia gravis. What about botulism? Well, you know that snare proteins are necessary for release of acetylcholine at the neuromuscular junction, and so you don't stimulate nicotinic receptors in botulism, and patients are very weak. Okay? Well, just like voltage-gated calcium channels, snare proteins are also necessary for release of acetylcholine by your parasympathetic system. So therefore, you don't release as much acetylcholine to stimulate muscarinic receptors. So this is actually quite similar to Lambert-Eaton syndrome in that these patients also have understimulation of muscarinic receptors for the parasympathetic system. And so classically in botulism, it's the pupil that's involved. And I don't have a good explanation for why Lambert-Eaton, it's mainly dry mouth and constipation. And with botulism, yeah, they also have dry mouth and constipation, but the pupil is usually big and dilated in botulism. And that's actually a helpful exam finding. Okay, what about organophosphate poisoning? So remember, with regards to the neuromuscular junction, organophosphate inactivates acetylcholinesterase. Okay, and so that's the enzyme that breaks down acetylcholine. So recall that if you have just a lot of acetylcholine at the neuromuscular junction, you keep bombarding these nicotinic receptors, which does not make you super strong. You inactivate them when you just keep, blasting them away with acetylcholine. So patients with organophosphate poisoning, farmers, come in with weakness, okay, but, we've got acetylcholinesterase used also on effector tissue out here. Remember, it's acetylcholine, right? So we break down acetylcholine by the parasympathetic system by the same enzyme, acetylcholinesterase. And so initially you have too much stimulation of muscarinic receptors out here on the effector tissue. So dumbbells is a way to remember the parasympathetic dysfunction in organophosphate poisoning. Okay, so if we overstimulate the bladder and the rectum, you get defecation and urination. Okay, if you overstimulate the pupil, you get meiosis. That's a small pupil. If you overstimulate the lungs, you get excessive lung secretions. That's known as bronchiuria. You get constriction of the bronchi, bronchospasm. Okay, this slows the heart, the parasympathetic. So overstimulation leads to a slowed heart rate, which is called bradycardia. Okay, the excessive stimulation of the GI tract causes nausea and vomiting. That's known as emesis. Okay, and not shown here, but the lacrimal glands are also excessively stimulated, so we get excessive tearing, which is lacrimation, and excessive salivation as well. Okay, so these are all of the features here of organophosphate poisoning. And I'm just remembering that I forgot to mention that we described botulism, but we can also inject botulinum toxin. For example, if we have a patient that has excessive drooling, that's called sialuria. That's really common in Parkinson's disease. So if we inject Botox or botulinum toxin into the parotid gland, for example, well, again, that's going to disrupt the snare proteins. You don't release acetylcholine on the muscarinic receptors in the parotid gland. And so this is very helpful for patients. It dries up all those excessive secretions. Okay. Remember also with the sympathetic system, you activate sweat glands through acetylcholine muscarinic receptors. And so individuals that have excessive sweating in the palms or in the axillary region, we can inject botulinum toxin there, and it dries up the excessive sweating. Years ago, I saw a medical student who was in his 4th year. He wanted to go on interviews, and he had sweaty palms and didn't want to shake hands with everyone. And so he had his hand injected with botulinum toxin and dried them right up, and he was able to shake hands confidently and had a good experience with interviews. Okay, now a class of medications that are commonly used called tricyclic antidepressants, amitriptyline and nortriptyline are the two most often used here, block muscarinic receptors. I mentioned atropine is something else. It's not an antidepressant, but it's another medication that blocks muscarinic receptors. Okay, so what, if you prescribe these medications, the more difficult route is to memorize the side effects. And when you see a patient, okay, I've memorized my list of things that this can do. The easier, more intuitive way is if you understand the parasympathetic system and that you're blocking muscarinic receptors, you can just kind of in your mind go through, okay, what are the potential side effects? Well, if we block acetylcholine muscarinic receptors here, that will affect the pupil, could cause blurred vision. Okay, if we block what's going on here, dry mouth, that's actually the most common side effect of these medications is dry mouth. Okay, if we block something here that normally slows the heart rate down, we block that, we'll get the opposite, and patients may have tachycardia. Okay, if we lose stimulation of the GI tract, constipation is a big-time side effect of these medications, and we may have urinary retention in addition to constipation. Okay, so easy way to remember the side effects then of these medications. So we really try to avoid these in the elderly because they often already have constipation and urinary retention. And it turns out that there are acetylcholine muscarinic receptors in the brain, lots of them. And so this can affect the brain as well and contribute to sedation and confusion. All right, the last condition we'll talk about is something where we have a distortion both of the sympathetic and parasympathetic system. And any of you that are involved in seeing patients, if you don't become a radiologist or a pathologist or something like that, you will all see patients with this. It's exceptionally common, and it's called diabetic autonomic neuropathy. Okay, and this is more common in people that have had diabetes for a long time, especially if it's poorly controlled. So the most common symptoms of this involve the cardiovascular system. Okay, so we distort the nice balance between the sympathetic and the parasympathetic system. And so these patients tend to have a resting tachycardia. The heart rate goes up. Okay, but when they exercise, they don't get the normal, continued elevation in their pulse rate that is needed for the exercise. So therefore, they have a pretty severe exercise intolerance. The autonomic system, remember, is so important for your blood pressure. And it's amazing what happens when you get up in the morning, if you just jump out of bed, how your autonomic nervous system is able to just precisely elevate your blood pressure to what is needed. But even with that, I think we've all experienced, if you get out of bed too quickly, a little bit of lightheaded dizziness, because it can take a few seconds for everything to just work perfectly. And so in patients with diabetic autonomic neuropathy, where they have a distortion of sympathetics and parasympathetics, they tend to have a significant drop in blood pressure when they go from lying or sitting to standing. And this is known as orthostatic hypotension. And so these patients will complain of dizziness, a lightheaded dizziness when they're on their feet. That's known as presyncope. Okay? And they can actually pass out when they stand up, or even just when they're walking around. That is known as syncope. So it is important when we have someone with diabetes that occasionally, and especially if they're symptomatic, that we check their blood pressure, lying down, then sitting, and then standing. Okay? And we diagnose orthostatic hypotension when you have a systolic drop of 20, a diastolic drop of 10, and in the neuroscience course we'll talk about the pulse, but that's a bit more complicated to go into for now. So we can objectify in your diabetic patient who says they're lightheaded and dizzy. We want to objectify if we have a significant drop in blood pressure. Autonomic fibers in the peripheral nerves are affected. And so patients tend to sweat more proximally. That's called hyperhidrosis. Not the proximal part. This just indicates too much sweating. And they lose the ability to sweat distally in their hands. So that's a hypohidrosis, and I think anhidrosis is a term that's more commonly used. So an alteration in sweating. Okay, it turns out that the autonomic fibers in your peripheral nerves are really important for maintaining the health of the skin and the nails. And so these patients often lose their normal skin texture. They can more easily lose nails, especially if there's some sort of trauma. And this contributes to the foot ulcerations, which are quite common in patients that have diabetes. Autonomic fibers in the GI tract are involved, and especially the ones here in the lower esophageal sphincter. And so this contributes to GERD, or gastroesophageal reflux disease, which is quite common in patients with diabetes. Autonomic fibers that supply the GI tract also contribute to poor gastric motility. So this is called gastroparesis. So patients tend to develop kind of an alternating constipation and diarrhea. And just the distortion of autonomic fibers at the GI tract leads to more frequent nausea. And then finally, the genitourinary tract is dysfunctional. And so incontinence is quite common in patients with diabetes. And in men, there's frequently erectile dysfunction, including retrograde ejaculation, where there's a desynchronization of these urethral sphincters. And so men usually notice this when they go to the bathroom sometime after sexual activity, and it's cloudy, and that is from semen that is in the urine. Women, due to the autonomic dysfunction, lose normal lubrication, and so can have some complaints of pain during sexual intercourse.